Hello, everybody. Welcome again. My name is Elma, and I am the coordinator of the Bold Public Health Center of Excellence on Dementia Caregiving. As I was mentioning earlier, we have a full agenda planned for today and a panel discussion, so we are going to move into it right away on time. We only have 1 hour. So as you can see, the topic of today's webinar is respite care. For dementia caregivers, respite is incredibly important. It really gives that essential time back for breaks and activities the caregiver needs, reduces burnouts, and really helps caregivers provide better care. And as dementia becomes a priority for public health, building an infrastructure to support caregivers in the community is a key goal for public health agencies. And respite is an essential part of that home and community-based support infrastructure. However, the administration and provision of respite care has traditionally been in the hands of the Aging Services Network, and as public health enters this space, health agencies are increasingly looking for ways they can support and sustain respite programming in their jurisdiction. So during today's webinar, we will hear from public health agencies that have engaged with respite programs in their states. And together we hope to, through conversation, identify some successful strategies that agencies elsewhere can replicate and can learn from. And before I hand it over to our speakers, I just would like to go over a few reminders for today's session. We always like to begin with a land acknowledgement, recognizing that the University of Minnesota campus here in Minneapolis is located on traditional, ancestral, and contemporary lands of Indigenous people. We are grateful for the land itself and to the people, and take to heart and commit to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity, which we hope you will see in our work today in the presentation of our colleagues on the call. Next slide, please. Many of you already are familiar with our center, so I won't spend much time. I invite you to scan this QR code and visit our website, but our center is one of the 3 national centers, really, and we are dedicating to supporting public health agencies nationwide at the state and local level and helping them build an infrastructure to address dementia, in our case, to an infrastructure system of supports to support family caregivers of people with dementia. And we do that in various ways by increasing access to evidence-based programs and promoting best practices by facilitating connections among public health agencies and a wide range of partners and service organizations. And finally, leveraging the knowledge and expertise of our center members and partners in providing technical assistance free to health departments. Just a couple of reminders for today. Use the Q&A feature in your Zoom bar to submit questions to speakers as you hear them talk and as your questions come up. The chat, please use it only to share comments, resources, and links or ideas. Or if the speakers ask you a question, you can also, sometimes we invite the audience's input as well. Please use the chat to submit those comments. But again, Q&A, we will be checking regularly for questions. Recording, slides, and resources will be shared after the event. And please let us know how we did, how you liked today's event. We really take your feedback seriously and use it to improve our program, future programming. You can scan this QR code to open that survey link, or it will pop up when you close Zoom. Thank you in advance. Just so we know who all is in this space, this virtual space with us, my colleague Ashley is going to enable a brief poll so that our speakers know who is listening and what they might be interested in. Thank you for responding. Responses are coming in, and I will share it with everyone when everyone has responded. I had a few still coming in. Thank you. All right, so I will share the results. Hopefully you can see them. About 20% are bold public health agencies and 14% in other non-bold agencies. So about a third is usual. We have public health agencies followed by 38%. Many of you are community-based organizations and service providers, as well as clinical professionals and caregivers. Thank you all for being here. Next slide. And without further ado, I want to hand it over to our wonderful speakers today. Thank you, Ms. Jill from the ARCH National Respite Network and Resource Center for leading us off. And then we will be joined by Kristen and Brooke from Idaho and Wisconsin to talk about their work with respite programming in their states. Thank you.
Thank you so much, Alma. I'm very delighted to be here. I appreciate the opportunity to share information with the public health community about respite care. I am Jill Kagan, the director of the ARCH National Respite Network and Resource Center. And for those of you who may not be familiar with ARCH, we're funded by the Administration for Community Living to provide training and technical assistance to the Lifespan Respite Care Program grantees. And I'm going to be talking about that program in a minute. To any other state and local agencies and providers, to family caregivers, and to the respite field more broadly. Today, I'm just briefly going to review what respite is so that we're all on the same page about what it is. The types and models of respite care, the benefits of respite that Alma talked a little bit about at the beginning, to what extent families use respite and some of the reasons that they don't use it as often as we would like. Again, a little bit about the Lifespan Respite Care Program and how it works at the state level to help reduce barriers to care. This is the definition of respite used in the Lifespan Respite Care Program, and that is planned or emergency care provided to a child or adult with special needs in order to provide temporary relief to family caregivers who are caring for that child or adult. And you'll see that the care is provided to the care recipient, but the focus is really on being a benefit for the family caregiver. And back in COVID, when formal services such as adult day services and even home care agencies had to close, we became a lot more flexible about the definition. Now respite can include informal services and supports that provide some type of break for the family caregiver and temporarily reduce their responsibilities for care. For example, respite might be in the form of virtual support groups or having someone assist with household tasks. Respite can be in-home or out of home. Formal respite services can be provided by home care agencies, adult day service centers. It can be provided in facilities like nursing homes or assisted living or hospitals, or it can be provided by community-based agencies. And in addition to the informal respite options that I mentioned a few minutes ago, informal respite may also include volunteer or faith-based respite, or respite that's provided by family, friends, or neighbors. Since 2019, ARCH has been seeking innovative and exemplary respite service models through a national call for applications. And our selection criteria are fairly rigorous, but at the heart of the definition of innovative and exemplary is that the program offers meaningful person and family-centered services. We look for programs that collect some outcome data, and have other characteristics that might make them easily replicated. And I selected just a few of our innovative and exemplary respite programs that serve older adults with dementia and their caregivers to share with you, because it might be something that at some point you could either support or replicate yourselves. The Neighbor Network of Northern Nevada serves 12 counties in Northern Nevada, many of which are very rural. Using a community village model, they serve adults not only with dementia, but also with intellectual and developmental disabilities. Respite is provided at no cost to families and can take place at home or in the community. But what's unique about this is that they tailor those activities to individual needs and wants. And the respite's provided by trained community partners, including tribal and bilingual partners. Musical Memories Cafe in New York is a model of respite we call shared respite. When the caregiver and the person with dementia attend the respite event together, getting away from the daily routines of caregiving, and they enjoy music and communal meals together, and they meet in community venues. And the demonstrated outcomes here have been not only reduced caregiver stress, but just as importantly, both the caregiver and the care recipient are able to reclaim that joy that's sometimes forgotten in the caregiving relationship. Caregiver Volunteers of Central New Jersey has provided weekly in-home respite care for persons with Alzheimer's disease and dementia for a long time, since 2002, using volunteers. And what's exemplary about this program is the very careful volunteer matching process, including matching families with bilingual volunteers, along with ongoing support and training for volunteers. That's very important. And that strong support of volunteers results not only in measurable improved quality of life among caregivers, but results in consistent volunteer relationships, many of which have lasted for years. And that consistency is very important in respite. The final example that I want to mention is the Home Away from Home Respite Center in Geneseo, New York, that's run out of the University of Rochester Medical Center. Here, respite's provided in weekly sessions at a local interfaith session. So there's that partnership with the faith community. But what's unique about this model is that respite is provided primarily by trained college interns, providing that very valuable intergenerational social contact that can be so critical. And this model of using students as respite providers is growing very rapidly across the country, especially among some of our lifespan respite grantees. Respite consistently ranks as a top need among family caregivers, as it did in the most recent, many of you may have read about this report in the news, Caregiving in the New U.S. report that was released by the National Alliance for Caregiving and AARP. Respite benefits have been well documented. That's why it's so beneficial to family caregivers. It's been found to relieve caregiver stress and anxiety, which in turn can improve physical and emotional well-being. We also know that providing some time away from caregiving responsibilities, respite allows family caregivers to spend time with others, and that can be very beneficial to their emotional well-being. We've heard a lot about the negative effects of social isolation. And of course, these things are very true for the care recipient as well. But despite the documented benefits of respite, families still don't make use of it. They can't find it or afford it. Again, the Caregiving in the U.S. study found that 87% of family caregivers are not receiving respite. And we know that for caregivers of people with dementia, while the reported use of respite has increased over time, respite is still severely underutilized or delayed. And some of the barriers are that family caregivers simply don't know what respite is. They don't know that it's something they could benefit from, or don't feel comfortable asking for help or for using respite. For certain, most don't know where to find respite or how to pay for it. And some of the reasons for this is that there simply are not enough public resources dedicated to formal respite services. And the system to navigate eligibility can be very confusing and sometimes overwhelming. A majority of care recipients and their family caregivers don't even qualify for publicly funded programs. So as a result, the cost of respite can become extremely burdensome, especially if a family caregiver had to give up employment to provide care. Unfortunately, we found that even when a family does have the resources to pay for respite, they still might be reluctant to leave the person they care for with someone they don't feel is trained or qualified. And most often, in the midst of this direct care worker crisis that I know many of you are quite familiar with, they just simply can't find respite providers or programs at all. There are multiple sources of federal, state, or private funding that can help families pay for respite. And in the interest of time, I won't go through all of them, but the largest federal source of funding for respite are Medicaid home and community-based waivers, followed by the National Family Caregiver Support Program, which is run through local area agencies on aging, and Veterans Administration programs. And I think there's also a Medicare and Medicaid innovation model called the GUIDE model that's now a new payment model that's providing comprehensive services for people with dementia, and also including respite in that model. As Elma said, it's a critical component of a comprehensive approach to providing Alzheimer's care. Some states have dedicated funding streams for respite for people with dementia specifically. Private funding might be through the Alzheimer's Association or Easter Seals or other private organizations. But there's really only one federal program that addresses all of the barriers that I outlined, and that's the Lifespan Respite Care Program. And that's because it is charged by the Administration for Community Living, who awards competitive grants to states to build or enhance statewide seamless systems of respite care. The Lifespan Respite grantees have been evolving over the last 15 years since the program began in 2009. All of them strive, of course, a number one priority to connect families to respite and ways to pay for it, to help expand availability of respite providers and programs by recruiting and training respite providers, through mini grants to community-based agencies, to provide respite, including volunteer and faith-based respite. And finally, most of the Lifespan Respite grantees are now providing self-directed respite vouchers or stipends to help families pay for care. And this primarily goes to those who are traditionally underserved, those on Medicaid waiting list, and again, that large population that don't qualify for other publicly funded programs. The Lifespan program remains a very small federal initiative. Unfortunately, not every state has a program in place. And here's a map of the current programs and their state respite coalition partners. And just to close out, I want to just share with you that we do have a robust website for caregiver resources that you can share with family caregivers, that has information on how to find, choose, plan for, and pay for respite. I know that was a very quick and fast overview, and I want to thank you again for the time to share this information, and I will be on the panel discussion and to answer any of your questions. Thank you. I'll turn it back to you.
Thank you, Jill. I know it was a lot of information, but all great information, and I hope you'll learn something. I sure did. It's so important really to really raise awareness of the potential of what respite can really do, especially for those of us who work with programs who later provide those respite services. I really encourage everybody to look at the innovation awards that Jill mentioned earlier. They are a source of great ideas and just really show some of that creativity, innovation that our community organizations are driving when it comes to different ways and different types of services that respite really can offer to caregivers. So let's now turn to a conversation with our panelists. Welcome, Kristen from Wisconsin and Brooke from Idaho. I would just invite you first to introduce yourselves briefly and tell us about your role and where you're joining us from.
I'll go first. I'm Kristen Felton. I'm the dementia specialist in the Wisconsin State Department of Health Services, in our Office on Aging, which is within our Division of Public Health, which is a unique structure, but has been incredibly beneficial. And I've been working in the field of dementia care since 1996 and with the state since 2006, focused on dementia since 2010. And I'll stop there. Thank you.
That's impressive, Kristen. I feel like I have so much to learn from you already. My name is Brooke Ambrose. I work with the Idaho Department of Health and Welfare running the Alzheimer's disease and related dementias program, which is also housed within our Division of Public Health here at the Department of Health and Welfare. Let's see, I feel like I'm missing a few things here, but I have a really great team that supports this program with me, so it's not just me. And I did want to highlight that we are fortunate enough to have both the BOLD and the ARCH Lifespan Respite funding that Jill was just talking about, so I'm hoping to share that perspective with you all today.
Thank you. Thank you both for joining us. So we have a few questions here prepared, but I will keep an eye on the Q&A and the audience, and we will have at the end some time reserved to take questions directly from the audience. Let's begin with just understanding what has your agencies, this is a question for Kristen and Brooke, how have your departments of health engaged in building that respite infrastructure in your state? Can you tell us a little bit that work? Kristen,
Sure.
you.
I can start. We've been very fortunate in Wisconsin that the need for support for family caregivers of people with dementia has been recognized for a long time. In fact, our Alzheimer's Family Caregiver Support Program is a state-funded program that came into existence in 1986 from State Senator Russ Feingold, who then, when he became our federal senator, brought that model to create the NFCSP program. So we're fortunate that we have both those programs available to the people in our state. And I would like to, sorry, I'm not being very quick with my online meeting skills, but I wanted to share a link in the chat to our AFCSP program. And I'll tell you a bit more about it as well. Again, it started in 1986 and has eligibility criteria that include both a financial eligibility requirement as well as a requirement of having a diagnosis. And I think we all know that that can be one of the difficulties in accessing care, depending upon how it is, how the program is set up, that requiring a diagnosis will make it more difficult for certain people to be able to access a program, because about half of the people in the most recent study from the Alzheimer's Association actually receive a diagnosis. So there are people who are in need beyond what that diagnosis is going to be able to give them access to. And I just want to make sure that we acknowledge that as well. So because it started in 1986, the financial eligibility criteria has not been brought up to current economic standards for a long time. So 30 years later, in 2016, we increased the financial eligibility from $40,000 a year to $48,000 a year, which is also still very low because those criteria were originally set up a very long time ago. And I'm happy to say that in this most recent budget that went through our state legislature, the financial eligibility criteria for this program has been eliminated entirely. So you no longer need to be restricted by income limits to be eligible to receive this type of support. And that's a big thing. So many of the services that people have access to are limited in those ways. So having something that they can access regardless is very important. And Lynn Gall is our caregiver program coordinator, and wanted to make sure that I say that this decision to eliminate the income cap was bipartisan and passed almost unanimously. That our state government, I can't speak for others, but is very supportive of the bills that come through in supporting people who are living with dementia and their families. So it's something that affects everyone. It doesn't care about your politics. So it can be something that is possible even in this current environment. And I'll stop there. Thank you.
Thank you, Kristen. Brooke, tell us about how public health got involved. What has public health has participated in respite?
Yeah. So our program is a little younger than Kristen's program. The ADRD program was also enacted through state legislation, but that happened, I believe, in 2021, if I'm remembering my timelines correctly. So we're pretty new here in this state. And I do kind of want to share a little bit more of why we took on the Lifespan Respite Grant as a program. So the Idaho Department of Health and Welfare took on the Lifespan Respite Program at the request of the statewide Caregiver Alliance and the Idaho Commission on Aging. So in Idaho, our aging statewide agency is separate from our statewide public health agency. And in the past, they had received these dollars, but they asked if we were open to potentially looking at taking over this grant so that we could honor the aspect that this was not just for adults over 50, which was a barrier that our Commission on Aging was experiencing. So due to this, it was determined that the department, and specifically public health, with our known ability to work collaboratively across silos, we could partner among several abilities and age groups to ensure that the respite services were increased throughout Idaho, and again, to ensure that preventative supports are available for caregivers across the lifespan and not just for those adults that are 60 and over. So the ADRD program specifically took this grant because we are the only program that focuses on the caregiver's health risk, which may potentially lead to their premature chronic disease outcomes and cognitive declines. So this shift in our state has helped avoiding duplicative efforts with our aging network, and it instead complements the other services in our state, which I know that a lot of other states are probably feeling this, but you only have so much money to spread to help out those folks in your state. So being able to complement services instead of duplicating was huge for us. And also wanted to highlight that many caregivers in our state support individuals with disabilities, veterans, or young children with complex needs. And this program provides an opportunity to address those needs more holistically as a collective. So with that being said, just to kind of summarize, that public health is uniquely positioned to offer these community-based upstream supports and identify gaps and engage with the at-risk population, which might not traditionally be reached through aging services alone, but in tandem through these collaborations. I will stop there too.
Thank you, Brooke. What a great example, really, of public health taking that population level really view and seeing opportunities for where different organizations, agencies really complement each other. What are the gaps? What a great role. Wonderful example. Thank you. Jill, Ms. Kagan, I want to turn to you with this next question. What are some of the challenges from your experience working at ARCH Respite? What are some of the challenges for sustainability of respite programs across the U.S.?
Yes, thank you for that question. There are many. As we learned last week from the new Caregiving in the U.S. Report, we're now up to 63 million family caregivers in our country. And so there will never be sufficient federal or state resources for all who need or want respite, especially in this current political climate, except for Wisconsin, where they seem more open to expanding respite opportunities. And we do have to be, relentless in advocating for those resources. But sustainability is not just about financing. While that's very important, it's all about developing those strategic alliances across everyone who's committed to supporting family caregivers. And Brooke just spoke so eloquently about that and how public health is uniquely situated to do that. It's about collaborating across aging and disability services, across public health and mental health systems. It's about seeking partnerships with the medical community and with social services, with private insurers, managed care, with higher education to help build the workforce, as we're seeing now with the growth of student respite programs. with faith communities who have a very important role to play in providing respite. And as Brooke has said, the public health community is already working across many of these domains and is really uniquely positioned to help build these coalitions and sustain respite services. Sustainability is also about having really good data and documenting positive outcomes so that we can demonstrate that respite is worth the investment from funders. Unfortunately, so many individual community-based respite programs may not have the resources, the skills, or the technology to do this well, can use more support. And this is another area where the public health community has strong skills, I think, that they can share. ARCH has a lot of resources to help respite programs sustain services, and I'm happy to put those links in the chat so that everyone can access them.
That's a great overview. As I heard you speak, it really aligns every single opportunity, every challenge. It really meets very well with those core areas of action for public health that are outlined so clearly in the Healthy Grid Initiative roadmap for public health. And that's why partnerships, policies to provide sustainable funding sources, data collection, opportunities for public health to really support respite. Kristen and Brooke, can you provide some examples? Can you speak a little bit to partnerships that Jill just mentioned that have successfully grown or supported the growth of respite in your states? I always think of partnerships, really public health reaching across those sectors, clinical, community.
You want to go first this time, Brooke?
Sure, I can. Yeah, we can trade off. I like that game plan. All right. So in Idaho, as we've all kind of been talking about already, collaboration really is key. So I'm going to list off a variety of the folks that we have worked with and are continuing to work with in our program here. We've worked with aging services. We've worked with faith-based groups and communities, community health workers, Medicaid, our newly strengthened foster care program with the state, our disability organizations, veterans groups, kinship programs, healthcare systems, senior centers, adult day centers, regional public health districts, area agencies on aging. The list really is endless. Once you kind of start looking into it, you realize how many lives caregivers touch, and it's really hard to find somebody who doesn't have an experience with caregiving or isn't related to somebody who has an experience with caregiving. So with that being said, just making sure to bring in that lifespan perspective into the public health in these conversations, it's really helped increase the awareness of family caregivers among other public health programming in our state. So some of those things I mentioned might not have had that lens before we started doing this work and we've really just kind of invited ourselves to sit in on a lot of meetings and start kind of introducing the conversations of how caregivers are so important in these discussions. I also really want to highlight our partnerships with the Idaho Caregiver Alliance and the Idaho Commission on Aging, who had hosted this grant for several years, the ARCH Lifespan Respite Grant, as well as the other organizations focused on supporting those with dementia and chronic illness. Without those partnerships and support, we would not be doing as well as we have been. And then again, hitting on what Jill was saying earlier, by pooling our knowledge, data, and resources together, we have really created a more supportive environment for caregivers and ensure that our programs reflect these real-world needs. And we can just provide a more united front in providing updated information to our policy and decision makers in our state so that they have a better understanding of what's going on in our state. And I will stop there.
Thank you, Brooke. I wanted to take the opportunity to sort of expand the lens a bit about what respite care is, because oftentimes it's considered only to be there's someone who comes to take care of that person who needs care and the caregiver is given a break. that's very simplistic. And that is something that people want and need and can benefit from. But there are a lot of other ways to provide respite and support for family caregivers of people with dementia that are not simply having somebody else come in and providing care. For one of the big things we've learned from our experience is a lot of people don't want that. They don't want a stranger coming into their home to provide this intimate care for their loved one for many reasons. No one can take care of them like I can. They don't know him like I do. Nobody can do this. And caregivers really have a hard time at times accepting that particular type of support. But there are a lot of other things that can be done to provide support. And the AFCSP program in Wisconsin, because this is what I know, is very broad in that it can be used, the funding, and it's $4,000 a year, although counties have the ability to manage that within their own structure. But $4,000 a year can be spent on having someone come and provide respite care, or building a ramp because now your loved one needs a wheelchair and you're no longer able to come and go from the house without one, or you desperately need a window air conditioning unit because it's no longer possible for each of you to stay living at home without one. And whatever is needed to help support a family, a person who's providing care, in addition to having someone come and actually provide physically in person that care, can be as sustaining and enabling and supportive in the ways that people really want. And everyone has unique needs and unique sets of issues that they find acceptable or not. And then to circle back to the actual question about partnerships, I will put in here the fact that we are, again, fortunate in Wisconsin to have a nonprofit respite care agency that we work with as well. So in addition to the AFCSP and the NFCSP, and I keep messing up my cut and paste, I apologize. We have the Respite Care Association of Wisconsin. And they're a nonprofit organization that helps in addition to those state and federally funded programs. So I'll stop there. Thank you.
Thank you, Brooke and Kristen. I think you already started some great insights, as for public health and public health agencies who are in our audience and those who will watch this later, some ideas of how to approach this respite space. So you already started answering my next question I was going to ask you. And we already have some in the Q&A, so I will just quickly invite you all three, now especially Jill, to just share any final thoughts on opportunities and roles. What opportunities and roles do you see for public health, in addition to what Brooke and Kristen said, to strengthening respite programs? What alignment opportunities do you see with public health priorities?
Do you want me to kick it off, Elma?
Sure. Yeah.
Well, as Brooke and Kristen have already mentioned, they're already partnering with their state respite coalitions, which in Wisconsin is the Respite Care Association of Wisconsin, or the Lifespan Respite Care Program grantees. But I would encourage other public health agencies to do that. And there are many ways you can do that. One is just by sharing very important information about what respite resources are available in your state, whether it's those self-directed respite voucher programs that Lifespan programs and others are dispensing. If it's a respite registry, many of our state respite coalitions maintain state respite registries to help find providers, or they've embedded those resources through their aging and disability resource centers or no wrong door systems. But there's also opportunities for public health, for example, to perhaps apply for a Lifespan respite grantees mini grants if they're offering them to community-based agencies to start up new or enhance community-based respite services. Local health departments would certainly be welcome grantees for those kinds of awards if the state is offering them.
Mhm.
And then there are also some other funding opportunities I wanted to quickly mention. I didn't get a chance to talk much about the Center for Dementia Respite Innovation, which is now funded by the Administration for Community Living and is overseen by the Alzheimer's Association. And they are annually awarding grants to community-based agencies to provide respite for family caregivers of people with dementia. And I know I'm on the selection committee for that project. And this year we just awarded a grant to the Erie County Health Department in Sandusky, Ohio, to enhance their adult day services. So again, this is another funding opportunity. And then finally, for state health departments, we heard two incredible examples in Idaho and Wisconsin about their public health initiatives to support caregivers of people with dementia. And there are others, and I quickly wanted to mention the New York State Health Department that has a tremendous state-funded Alzheimer's disease caregiver support initiative, and I'm sure you've heard about it through this webinar series. But they do include respite care as part of that initiative, using volunteers and paid individuals through contracts with the Alzheimer's Association and other healthcare and community-based providers across the state. Respite's a core component of that particular Alzheimer's initiative. It was just another great example of what Idaho and Wisconsin are already doing too.
Great, thank you, Jill. And I did plug in a couple links that you mentioned into the chat for Kristen and Brooke. Would you like to add anything else to this final question before we turn to the Q&A? Any other opportunities that come to mind for public health?
I think just again, reiterating what Jill was saying, if you can connect with your state respite coalition, or if your state has a lifespan respite grantee, definitely connect with them. Those relationships can open doors to shared funding opportunities and establishing stronger safety net for caregivers. And as Jill was saying, Idaho does use some of this funding to seed for pilot programs and new initiatives. So you never know what it might lead to. And again, just touching on the value that public health brings with insights to population level data, program evaluation, and program strategies, which in the long run can really provide that infrastructure to enhance the reach and sustainability. Sustainability is huge, the sustainability of these programs. And I will stop there.
All right. Kristen, can I turn to the questions, or do you have anything else?
We can go to questions.
Cool, thank you. All right, so really good ones here that we've received. Jamie Zobrist, what outcomes do you use to show funders, legislators, that your program is working, especially related to caregiver health? All three of you, I think, Jill, from your work with the awardees and other respite programs, all three are welcome to answer.
Well, again, funders are looking for effective programs. And if respite is meant to be a service that benefits the family caregiver, the extent to which you can demonstrate benefits for the family caregiver, again, reduce stress, improved social engagement. And I know everyone is always looking for cost benefit data as well. And while that's a lot harder to come by, there are other ways to talk about the value of respite. And we've actually, through our Committee for Advancement of Respite Research, developed a model, a framework for measuring the value of respite. And I'd be happy to share that with folks as well.
How about Kristen and Brooke? Anything else that, especially as you think interfacing and communicating with legislators, how do you communicate the worth of the program?
So in Wisconsin, there have been a couple of incidents that have been in the press. So they have raised the awareness of particular situations related to dementia caregiving. And there have been a number of things that have happened as a result of that. Some legislative study committees were put together, and currently Our governor and especially the First Lady are very interested in family caregiving for people with dementia as a topic. And through their support, we also, and I'm about to put this in the chat, is again, and many projects for family caregivers are not dementia specific, but a lot of the resources and supports and funding that's available could certainly go to supporting caregivers of people living with dementia. So this is our sort of governor-supported Family Caregiver Support Alliance organization in Wisconsin as well. I just want to encourage people to reach out to legislators. One of the things we've found as well is that, and a lot of people who don't live in the dementia world may not realize, but there are a lot of people whose lives are touched by somebody living with dementia. In fact, most people. It's been really unusual in my career to meet someone who hasn't known someone in their lives who had been impacted. So our legislative study council on our assembly, which is like our house, there were a bunch of family caregivers who were our legislators. So find those people in your legislature who have experience, personal experience, and that can make a big difference.
And I just want to emphasize how amazing ARCH's resources are. Please look at that framework that Jill shared. We use a lot of their resources in our program. So I'd say a lot of our things came from some of those ARCH resources, but specifically some metrics that we frequently will look towards. Through our ARCH funding, we're able to administer a caregiver survey to really understand what's going on with caregivers in our state, where is their stress level and burden at, what can we do to support them. So being able to have resources like that have definitely made a really big difference. But if you don't have that funding yet, things that we've looked at to get this type of funding is the population in our state. Looking at our demographics, our population is aging at an exponential rate. Most of the people moving to the state of Idaho right now are also 60 and up. And then showing the justification of how many of those folks that are in those age ranges that are experiencing the need for a caregiver at home and things along those lines. Really just looking at your demographics in your area, I think can help outline what that picture is to help you get some funding in the future.
Mhm.
Can I just add to that quickly, Alma?
Sure.
I focused on the data and how important the data is, and Kristen raised other issues. And I want to reiterate and reinforce what she said about also the value of personal stories. We can share all the data in the world, and we know how data is so easily dismissed these days. But the personal stories are true and long-lasting and compelling. And collecting those and sharing those and finding advocates from within the family caregiving community is a very, very powerful advocacy tool.
Wonderful.
And
Yeah,
I'll say that again, you never know who's a family caregiver.
Exactly.
So
Like everybody.
my mom accessed all the programs I've just been talking about in order to once a week go and volunteer at the VA because she was a retired nurse, but she was taking care of my dad. So once a week, she got to go and be with her homies and in her space and get that, reinvigorating break to go and be herself. So I've seen firsthand the benefits and have lots of stories I could share in addition to your point, Jill.
Yeah. Yeah, the lived experience is something our center really, really strongly advocates for in all of our work in public health. I mean, public health already does that, really involving people who have experience navigating and using the systems and know really how they play out in real everyday life, how easy or truly difficult or helpful services are, right? And great points. I see, Jill, you're typing an answer to this question, but perhaps you would like to answer it maybe here verbally. Could you talk a bit about any intentions, perhaps just perceived, about volunteer/unpaid respite and student respite and fair wages for paid respite care providers. Any thoughts?
I'm not very aware of tensions between those groups because we need every type of respite that's available. There's not enough. We'll never have enough paid providers. We certainly don't have enough professional caregivers right now. So we have to look to the volunteer and faith-based community. We have to look to student any place where we can draw qualified, well-trained volunteers. I think it's a very important supplement, and doesn't at all compete with what's out there for families generally. Now, when it comes to wages for paid providers, of course, they're too low. That's one of the reasons we have our direct care workforce crisis right now. So at the same time, we're building up the volunteer and faith-based respite opportunities. We have to be working to build that direct care workforce, enhance their benefits and wages in order to increase recruitment into the field. And respite is actually a very excellent first step for engaging people who might be interested in providing care but aren't sure they want to do it full time. So perhaps you start out at a lower paying respite position for fewer hours a week, but it might lead to a career ladder and other training opportunities that can then fully develop the whole overall direct care workforce as well. I mean, those volunteers and unpaid providers can become a stepping stone to building the workforce.
By all means, totally. This is a question for Wisconsin from Eric. For the $4,000 per year in Wisconsin, how is that distributed? Is that in one sort of voucher? Does a participant need to get approval? Or
So it's a population-based allocation by county. And then the counties are the ones that administer the funds, and the $4,000 cap is per family. But some counties that are bigger have a smaller cap. So in a really populated county, it may be $2,000 or $3,000, but the state cap is $4,000 per family per year.
and I know this is there really isn't, probably there isn't a clear answer, but what is the cost of using the respite resources for those not on Medicaid, those who don't qualify? What is usually the range for a family?
Out of pocket?
I assume, yeah.
A lot.
I mean, the cost varies widely, depending on whether it's care provided by a home care agency or a facility-based nursing home or assisted living. Costs are going to be much higher than a home care provider. It's also dependent on geography. If you live in Florida, the cost of a home care aide is going to be considerably less than it is in Washington, D.C. or New York. So there are wide geographic variabilities as well as the types of respite provided. And and the folks who are using self-directed respite vouchers negotiate their own hourly wage with whomever they're selecting to be their provider. If they're using family and friends, they can work it out between them what the cost will be. So there's a lot more flexibility there.
Mm-hmm. And I just see a question. Thanks, Kristen, for answering it. Can tribal ADRCs utilize these funds? And you said that yes, tribes have their own allocation starting in 2016. Okay. And this is perhaps just me trying to need to understand. So tribes, that each community has their own a respite service network or respite services, or do usually tribal members, elders, family, caregivers, do they reach outside of the tribe?
Yeah, so it's basically a funding contract from the department, the State Department, to the tribe. Here's the funding for this purpose. And then the tribe has to administer it, figuring out who's going to provide those services and what their particular qualifications are going to be for eligibility.
Yeah, and out of curiosity, are you familiar, any of you, with any cultural adaptation that has been done to respite services, respite programming, to better fit needs of families and tribal communities, rural, urban?
Absolutely. We've had a few grants that clearly demonstrate culturally there are distinctive, differences around how families support somebody who's living with dementia. Um, an important distinction we've learned probably in the last 8 years is that in African American communities, there's not just one family caregiver. It's a family thing. It's two or maybe three of the adult children are all collaborating to provide that support. So if you're signing somebody up for something, who do you sign up? Well,
Yeah.
so it's important to pay attention to the cultural significance of
Mhm.
what people need and what they want.
And are the funding streams, are the criteria really accommodating these learnings? For example, in cases where there is more than one person supporting the elder living with dementia, can that
The
be
the reality has
flexibility?
been that people are figuring out how to work the rules to make it work for their lives,
Yeah,
as happens in so many things. So it would just be one of the three sibling caregivers that was designated, but that they still, would receive the funding, but use it in the way that makes most sense for how they are providing care.
yeah. Um, I'm looking in our chat and again, for any other pending questions. Jennifer asks, is there a complete list of grantees? Jill, I think you might have put this link in the chat already, right?
One thing I can
Yes,
quick
I did.
add. Oh,
Mhm.
go ahead, Jill, if you have something.
No, I'm sorry, I did. I put the link in the chat. Yes.
Thank you.
I see a question about the Hispanic population, and we are currently very active in a project with our Hispanic Health Resource Center in southeastern part of the state. And they have been successful in continuing their relationships with the community. All their programming has continued to be full. So I'm happy to report there has not been a big impact in a negative way to their services.
Incredible how resilient, creative, innovative community, cultural, especially cultural service community organizations are. Well, I think anything else, Brooke, you would like to add? We really don't have many questions.
I don't think so. Just reiterating that ARCH is an amazing resource. So definitely don't sleep on them. They have a lot of things on their website that might be able to help answer some of these questions that folks are having in the chat and in the Q&A box. And don't be shy to invite yourself to meetings, to that table, to start asking the questions and getting family caregivers looped into the conversation.
I would just add to not feel overwhelmed because this has been a lot and there's a lot to do, and that's okay. Start small. Start somewhere, pick something that you feel is achievable and get a win under your belt early on before you try to take on the whole thing. So just do something.
Oh, Jill, before you say your final words, can I ask you one more question that has come in the Q&A about the Texas State Coalition, I assume Caregiving Coalition or Respite Coalition. Is there a central website or page one can visit to see all the coalitions currently?
Yeah, I did put that in the chat, at least the contact information.
Perfect.
For the state coalitions and the lifespan respite programs. It is mandated in the Lifespan Respite Care Act that every grantee work in collaboration with a state respite coalition. So wherever there is a grantee, there is a coalition. But we do have some states that have coalitions, but no grantee because they've been around for a long time. So all that information is on that map and the link to the map.
And I think we have 1 more minute and 2 more questions came out. So I'm just gonna ask you again, Jill, this one is for you. Does ARCH accept any programs to be listed on their website or just grantees? And do you accept all from national or any specific states excluded?
Are they talking about being programs that offer respite services? Is that? We do have a national respite locator service that supplements what the state lifespan respite grantees provide for information. And if you're a licensed or registered respite provider, you can add yourself to that national respite locator service, if that's what they were asking about.
Okay. And I'm going to put it in the chat here, the link. Yeah. Well, now we are at time. We've done a lot in 1 hour. Thank you, Jill and Kristen and Brooke, for being here with us today, answering all these questions. And we really hope that this was helpful to all of you in the audience, especially public health agencies and professionals, as you think about ways you might be able to engage and support programming, respite programming in your state or your locality. Thank you again. And we hope that you will join us soon.
Thank you for the opportunity.
You are welcome. Have a wonderful day, everybody.